Stimulants are often described as life-changing for ADHD. For many, that first dose of methylphenidate or dexamphetamine feels like putting on glasses for the mind. Suddenly, the world sharpens into focus. But here's what many don't realize. When ADHD overlaps with autism, which, depending on the study, can happen in up to 80% of cases, the same stimulant can create a completely different experience. Instead of clarity, it can crank up arousal. Instead of flexibility, it can lock the brain into rigidity. And instead of relief, patients sometimes tell me, I feel anxious. It just doesn't feel right. Or, I just shut down. So why do stimulants work so differently when ADHD and autism collide? And more importantly, how do we as clinicians, parents, or even patients approach treatment in these cases? That's exactly what we're going to unpack. Stick with me because the answer lies not just in the medication, but in the neurobiology. So let's start off with the contrast and making it really clear. In ADHD alone, stimulants usually improve attention, reduce impulsivity, and transform functioning. In ADHD plus autism, those same medications can amplify anxiety, heighten sensory overload, or embed rigid hyperfocus. So here's the plan for this video. First, I'll explain what's happening in the brain when autism is part of the picture. 2, we'll look at what this means in real-life clinical presentations. And finally, we'll map out how to shift the treatment lens to get better outcomes. I'm Dr. Sanil Rege, and I've treated hundreds of patients across ADHD, autism, and their overlap. And the pattern is pretty consistent. The stimulant isn't wrong. The brain is different. And at the end of this video, I'll also share practical strategies I use in my own practice to help these patients optimize their response to stimulants. So let's start with the overlap. ADHD and autism are not rare companions. Depending on which study you read, 50 to 80% of people with ADHD also meet criteria for autism spectrum disorder. Yet in clinical practice, people often get funneled into one diagnostic box. You have ADHD or you're on the spectrum. Rarely do they get recognized as both. And that's where the trouble starts. Because if you don't account for the brain circuits in autism, you'll be left scratching your head when stimulants don't behave the way you expect. This isn't just a diagnostic nuance. It's the difference between a treatment that helps and a treatment that backfires. Now let's zoom in on autism. Autism is characterized by heightened baseline arousal. Now what does that mean? In autism, the amygdala is hyperactive. Sleep is often poor or irregular. Allergies and inflammatory conditions are more common. And sensory sensitivities to sound, light, texture, smell are exaggerated. In other words, the system is already running hot. So how does this brain cope with this constant overactivation? It leans heavily on top-down inhibition. The prefrontal cortex acts like a heavy brake. Stay focused, don't shift, keep it stable. This heavy brake system shows up as hyperfocus, rigidity, reduced cognitive flexibility. On the surface, it looks like impressive control, but underneath, the system is revved too high and straining. This is the baseline we're working with in ASD, and it changes everything about how stimulants are experienced. So what happens in ASD when we add stimulants? In ADHD alone, we know that stimulants increase dopamine and noradrenaline in the synaptic cleft, and when this happens in the prefrontal cortex, that boosts top-down inhibition. It improves signal-to-noise and allows attention to be directed where it's needed. But in ADHD plus autism, the baseline arousal is already high. The top-down inhibition is already tight. So instead of leveling things out, stimulants push arousal even higher. The results can look very different. Anxiety and fear-like states. The brain interprets the heightened arousal as threat. Sensory overload, sounds and lights suddenly feel intolerable. Emotional blunting, feelings become hard to access or describe. Deeper hyperfocus. Instead of flexible attention, the patient becomes locked into a narrow channel. And here's an important aspect. Because alexithymia, a phenomenon where recognizing and naming emotions is difficult and is common in autism, the patient can't give you detailed feedback. All they can say is, I feel anxious, I feel weird, I don't like this. This is why stimulants feel so unpredictable in autism plus ADHD. It's not random, it's a collision between an already hyperaroused system and a medication designed to amplify control. Now you might ask, is this just theory? The answer is no. The data backs it up. Large trials show in ADHD alone, stimulant response rates sit around 65 to 70%. In autism plus ADHD, response rates drop to about 50%, and discontinuation due to side effects jumps from under 4% to almost 20%. That's a big difference. So yes, stimulants can still work in autism plus ADHD, but the odds are different and the side effect profile is greater. So how do we take this into account and prescribe stimulants effectively? Here are 5 strategies I've found useful in clinical practice. First, start from arousal. Don't begin with, let's fix focus. Begin with, how's your sleep? What's your sensory load? What's your baseline state? If arousal is already sky high, stimulants will almost always tip things over. 2. Start low and go slow. Small doses can make a big difference. Individuals might not be able to tolerate 10 or 20 milligrams of methylphenidate, but may tolerate half the dose. Methylphenidate may be more appropriate than dexamphetamine. Third, build prediction and awareness. When prescribing, I tell patients, here's what to expect from this dose. Notice what changes. That way, they're not collapsing every sensation into anxiety or overwhelm. Instead, they learn to match prediction to outcome, a skill that can sometimes be underdeveloped in autism. Fourth, expand interoception. Help patients connect body to emotion to thought. This may involve therapy, mindfulness, or somatic work. Without this, medication feedback is vague and titration becomes guesswork. And fifth, broaden the toolbox. When arousal and anxiety dominate, I often consider alpha-2 agonists like guanfacine or clonidine first. Atomoxetine can also play an important part. Alpha-2 agonists such as guanfacine or clonidine can calm the system down, sometimes making stimulants more tolerable in combination. So here's the big reframe. In ADHD alone, the target is often enhancing cognition and regulating activity. In autism plus ADHD, the first goal is different. Reduce arousal. Expand emotional awareness. Because once arousal is under control, stimulants stop fighting the system and start supporting it. That's when we see the real benefits. Not just better focus, but improved flexibility, healthier emotional regulation, and reduced distress. This shift in mindset changes everything. It moves us from a one-size-fits-all stimulant protocol to a personalized strategy that respects the autistic brain. So here's the key takeaway. When ADHD and autism overlap, stimulants don't always fail. But they land on a brain that's already running hot. Think of it like pouring fuel into an engine that's idling at maximum revs. Instead of smooth acceleration, you get a shaky, unstable ride. The solution isn't abandoning medication, it's shifting the lens. Start with arousal, build awareness, use the right dose, the right scaffold, and sometimes the right alternative. When those foundations are in place, stimulants can finally do what they're meant to do: support and stabilize the brain, rather than overwhelm it. If you found this breakdown helpful, check out my other videos on ADHD, autism, and emotional regulation. And for clinicians, we dive deeper into these complexities inside the Academy by Psych Scene. I'm Dr. Sanil Rege, and I look forward to seeing you in the next video. Until then, stay curious. Bye-bye.